I was asked to talk about this topic, polypharmacy in an aging population, and implications for antiretroviral therapy. This is a topic I've been interested in for some time, and the older I get, the more interested I become. So I think it's obvious to probably everyone here that the HIV-infected population is aging. This is a study that basically modeled the increase in HIV-infected patients over the age of 65 over the next several decades, and also took a look at the likelihood of the increased prevalence of comorbidities associated with aging in this population. And those comorbidities include cardiovascular disease, hypertension, dyslipidemia, diabetes, and non-AIDS associated malignancies. So although this sounds like a big problem, I should remind you that it's actually a good thing that people with HIV are aging, because it means we're treating the underlying infection and they're living long enough to get all of the things that happen to aged people who do not have HIV infection. It's also probably not a surprise to any of you that the older we get, the more prescription drugs we tend to take. This is from a review published by Janice Schwartz a little over 10 years ago, showing the increase in prescription medications in a variety of classes for people in the decade of age 65 to 74 and people over 75 years old, showing, not surprisingly, that most of this increase in prescriptions is in drugs for cardiovascular disease, hypertension, diabetes, other anticoagulants, other diseases associated with aging. So as you take more prescriptions, you accumulate more pills, and that's true for both HIV-infected and HIV-uninfected individuals. But this is a study that compared pill burden in those with HIV infection to a control group that was HIV seronegative. The HIV-infected group is in the purple box and whisker plots, and the seronegative group is in the green. And you can see that if you include the antiretroviral drugs, there is an increase in pill burden in both HIV and seropositive and seronegative individuals, going from the decades below 40 up to greater than 60. And in this particular study, at age 60 and above, including ARVs, the average HIV-infected individual was taking 9 pills per day. Pretty extraordinary pill burden. If you exclude ARVs, the pill burden drops down to about 3 pills per day. But regardless of whether you include or exclude ARVs, the HIV-infected individuals have a statistically significantly higher pill burden than the matched seronegative controls. So as you prescribe more pills to more older people, there's a risk that some of those prescriptions may actually be medically inappropriate. And here is a study published in the Journal of the American Geriatric Society in 2014 showing the increase in potentially inappropriate medications, PIMs, in HIV-positive patients. This study compared 94 HIV-infected patients to 28 age and gender-matched controls, and what they found was that more than half of the HIV-positive patients had potentially inappropriate drugs, as compared to about 30% of the uninfected patients. Drugs with anticholinergic side effects in the geriatric literature are particularly bad actors with respect to adverse effects. And 17% of these HIV-positive patients were taking drugs that gave them an anticholinergic risk score of greater than 3. That is, chance of having anticholinergic side effects, including confusion and falling. As you take more pills and you have more potentially inappropriate medications, you have the possibility of cumulative effects the older you become. And that's shown in this study published last year, looking at the common comorbidities in older HIV-positive patients, as well as the increase in the number of non-HIV medications the older we get. So in this study, the cumulative number of patients who had up to 20 or more non-HIV medications was all the way up to 90% in this cohort. That is, as 90% of this cohort had up to 20 co-prescribed medications, many of which were potentially inappropriate. So what were the bad actors? The bad actors included opiates without bowel stimulation, duplicate drug classes, first-generation antihistamines, that is, those with a greater anticholinergic side effect profile, inappropriate aspirin dosing and other anticoagulants, long-acting benzodiazepines, non-selective beta blockers, et cetera. So more drugs means more polypharmacy, means more risk of drug interactions. And here's a cohort study looking at risk of antiretroviral drug interactions in an aged HIV-infected population. This was a study of more than 3,500 patients from the HOPS cohort. And the drug interactions in medical records were identified using the University of Liverpool Drug Interactions website. 7% of this cohort were prescribed at least one absolutely contraindicated ARV, non-ARV drug combination. And the most common absolutely contraindicated prescriptions were proton pump inhibitors concurrent with atazanavir, simvastatin or lovastatin with a boosted PI, benzodiazepines in a boosted PI leading to increased benzodiazepine effect. And overall, more than a third of these patients were prescribed at least one ARV, non-ARV drug combination that was felt to have moderate or high evidence of a potentially clinically significant interaction in the Liverpool database. So our ARV medications are getting better. We think their side effect profile is getting better. So our integrase inhibitors, the current, we're in the age of integrase, are integrase inhibitors actually less susceptible to drug-drug interactions? Well, it's important to remember that although integrase inhibitors overall have a greatly reduced potential for drug interactions, they are not free of drug interaction potential. And one of the most common and most important is the possibility of chelation with divalent cations. So integrase inhibitors work by binding to a critical magnesium cation in the active site of the integrase. The person who discovered that is in this room, so I don't want to say any more about it. But thank you, Daria. But because integrase inhibitors bind to this critical magnesium cation, they can bind to other divalent cations in the intestinal tract, particularly magnesium and calcium-containing antacids. So here's a study that looked at the impact of magnesium-containing antacids given concurrently or 2 hours after dolutegravir on dolutegravir concentrations. And if you give magnesium-containing antacids concurrently with dolutegravir, you dramatically reduce dolutegravir absorption. The same is true for bictegravir and other integrase inhibitors that also bind magnesium. If you give the antacid 2 hours after the dolutegravir, you greatly reverse this drug interaction. So the recommendation is that you give divalent cations 2 hours before or 6 hours after integrase inhibitors. What about calcium and iron supplements? Here's a study that did the same thing with calcium and iron supplements, iron on your left and calcium on your right. a very similar effect, except that if you give calcium and iron supplements with food, you essentially negate the impact of calcium or iron on the absorption of dolutegravir. And so you can give calcium and iron supplements at the same time as an integrase inhibitor if you give them with food. And this is important because many of our elderly patients are taking calcium supplements to prevent osteoporosis. Fewer taking iron supplements, but iron supplements also not uncommon as we age. Okay. There's one other thing that integrase inhibitors can do that can lead to potentially clinically significant drug interactions. Although integrase inhibitors do not interact in a negative way with drug metabolizing enzymes, they can inhibit a common drug transport protein called OCT2. And that protein is involved in the transport and excretion of metformin, a commonly used anti-diabetic drug. And so both dolutegravir and bictegravir inhibit OCT2. Both dolutegravir and bictegravir can increase concentrations of metformin. And so on your left, you can see that once a day dolutegravir, 50 milligrams once a day, increases the metformin area under the curve by about 80%. Twice a day dolutegravir increases the metformin AUC by nearly 150%. With bictegravir given as the fixed dose combination with M-tricytidine and TAF, the impact is not as great, but bictegravir still increases the metformin AUC by about 40%. The good news is that metformin-induced lactic acidosis, the most feared side effect of metformin, is actually quite rare. And most cases are related to the underlying condition of the patient and have an imprecise association with metformin concentrations. So there's increased risk of lactic acidosis with metformin if given to people with underlying renal insufficiency, and also with higher doses of metformin greater than 2 grams a day. And so be aware that in elderly patients, as our GFR drops with age on average, this can be a more important side effect in the elderly than in younger patients, and certainly something that warrants monitoring for both dolutegravir and bictegravir. But these drugs can be given together with close monitoring, particularly if you avoid their use in patients with renal insufficiency or with higher metformin doses. So overall, things look pretty good with integrase inhibitors and drug interactions in patients with polypharmacy, but don't forget about the association of reduced absorption with divalent cations and the potential impact of inhibition of OCT2 with dolutegravir and bictegravir. Gastric pH does not appear to have a significant impact on absorption of integrase inhibitors, except that raltegravir absorption is actually increased modestly with acid-reducing agents. All right, so I'm going to finish up with this point. What do you do to manage polypharmacy in your older patients? I think the problem has been well described. It's predictable given the epidemiology of the HIV epidemic. So what are we going to do about it? Well, here I think we have a lot to learn from our colleagues in geriatrics and gerontology. So first of all, it's important to keep track of the medications your patients are taking. Review your patient's medication list, including over-the-counter drugs at every visit. Evaluate whether every drug on that list is necessary and eliminate those drugs that are duplicative or not necessary. Be careful to pay attention to side effects that especially affect the elderly. So for example, anticholinergic drugs with anticholinergic effects are particularly bad actors and should be avoided if at all possible. Similarly, sedatives, especially sedatives with long-acting effects like benzodiazepines, should also be avoided. Check that the dosing of your drugs is appropriate and the duration of treatment is appropriate. Check for drug-drug interactions if you're not sure. And make sure you ask your patients to bring all of their medications to visits, as patients, especially in the United States, may be receiving medications from multiple sources. So our colleagues in geriatrics use the Beers criteria to assess whether or not prescribed medications are appropriate for their elderly patients. So what are the Beers criteria? Well, the Beers criteria look at classes of medications and try to help us avoid situations that frequently get the elderly into trouble. For example, there are drug classes to be avoided in most, if not all, older adults. That includes benzodiazepines and chronic proton pump inhibitors. Remember, there's now excellent data about proton pump inhibitors being associated with osteopenia, osteoporosis, and increased risk of fracture. And the recommendation is that proton pump inhibitors not be used for more than 8 weeks at a time in elderly patients. There are medications to avoid in older adults with specific diseases or syndromes. For example, staying away from nonsteroidal anti-inflammatory drugs in people at risk of renal insufficiency, and staying away from anticholinergics, benzodiazepines, and H2 receptor antagonists, especially in patients with underlying cognitive impairment. Finally, groups of medications to be cautious about. Any drug with anticoagulation or bleeding risk in general, for example, aspirin and platelet antagonists, as well as warfarin. Don't forget that as we get older, there is a statistical average decrease in estimated glomerular filtration rate, and so be careful with drugs with narrow therapeutic indices in patients who have the onset of renal insufficiency. So here's my summary. Don't forget, aging is associated with polypharmacy. Almost nothing we can do about that except to be aware that the problem exists. Polypharmacy is associated with a greater risk of clinically significant drug-drug interactions. Magnesium and aluminum-containing antacids lower concentrations of all approved integrase inhibitors and should be given 2 hours before or 6 hours after, or just avoid it altogether, since you can give proton pump inhibitors to control heartburn in patients who are taking integrase inhibitors. Calcium and iron-containing supplements should be taken with food, or given 2 hours before or 6 hours after integrase inhibitors, and both dolutegravir and bictegravir can increase concentrations of metformin by inhibition of the OCT2 drug transporter. So if you only take away one thing from this talk, take away this. Clinically significant drug-drug interactions are common in the elderly, and they're likely to become more common as our epidemic evolves and as our patients become older. And so thanks to David Back, University of Liverpool, and Katia Marzolini at the University of Basel, who shared much of my data and the thinking that I presented with you this morning. And don't forget, HIV drug interactions are very hard to keep up with, but the HIV drug interactions website is just one click away. Thanks.